Good afternoon, and thank you for joining us for this special virtual expert theater, VASCEPA icosapent ethyl, Elevating the Standard of Care. My name is Andrew Watson, and on behalf of my colleagues at Amarin Pharma, we are happy to be able to sponsor the National Lipid Association's LipidPALOOZA series, offered in celebration of the National Cholesterol Education Month. If you have any questions for us during this event, please submit them through the Q&A section on the right-hand side of your screen. We will address as many as we can at the end of this session. You can also view our handouts and important prescribing information by clicking on the handout section of your screen or visit VASCEPAHCP.com. It is now my pleasure to introduce Dr. Alan Brown. Dr. Brown is the Chief of Cardiology at Advocate Lutheran General Hospital and the Director of the Lipid Clinic. He is the past President of the National Lipid Association and a Clinical Associate Professor of Medicine at Loyola Stritch School of Medicine. Please welcome Dr. Brown.
Thank you very much, Andrew. And thanks to all of you for taking the time to support the NLA as well as to listen to this presentation this afternoon. So we will get started. Let me just point out that I am acting as a paid consultant for Amarin for this presentation. So I'm speaking on behalf of the company. This is not a CME presentation. For that reason, the slides that I'm using have been provided to me by Amarin, and I'm obviously fine with them, as I'm sure you will be. And my comments will be consistent with the label for VASCEPA. So what are the FDA-approved indications and limitations of use for VASCEPA? So the current indications are that ethyl ester of icosapentaenoic acid is indicated as an adjunct to maximally tolerated statin therapy to reduce the risk of myocardial infarction, stroke, coronary revascularization, and unstable angina requiring hospitalization in adult patients with triglyceride levels greater than or equal to 150. And those patients either have to have established cardiovascular disease, that would be cerebrovascular, peripheral vascular, or coronary disease, or they have to be, as was labeled in the trial, primary prevention, but they have to have diabetes plus 2 additional cardiovascular risk factors. Now that's a new indication because, as you all remember, there was a previous indication for patients that had triglycerides over 500, but the new indication to reduce cardiovascular events was based on the REDUCE-IT study, which we'll talk about shortly. The limitations of use are that the effect of VASCEPA on the risk of pancreatitis has not yet been determined. Safety issues that we need to discuss are that there's a contraindication in patients with known hypersensitivity to VASCEPA or any of its components. There was a slight increased risk of atrial fibrillation or atrial flutter requiring hospitalization in the outcome trial of REDUCE-IT, which we'll talk about. And those who had a previous history of AFib or aflutter were at a slightly greater risk of atrial fibrillation than those who had not. It's not known whether patients with fish or shellfish allergies would be at an increased risk of an allergic reaction. Patients with those allergies can be considered to stop VASCEPA if any allergic reactions occur. And of course, I always warn folks to be cautious if the patient has had a severe or life-threatening fish allergy. VASCEPA was associated with an increased risk of bleeding, which was 12% versus 10% in a double-blind placebo-controlled trial. The bleeding was greater numerically in patients receiving concomitant antithrombotic medications, such as those on aspirin, clopidogrel, or warfarin. And in terms of adverse reactions in the cardiovascular outcomes trial that were greater than 3% and more frequent than those in placebo were musculoskeletal side effects, peripheral edema, constipation, gout, and, as mentioned earlier, atrial fibrillation. In terms of common adverse reactions in the patients that were treated for hypertriglyceridemia, in other words, that occurred more than 1% and were more frequent with the drug than with placebo, that included arthralgias, oropharyngeal pain. and adverse events should be reported. I think that, things like AFib and bleeding are things that need further post-marketing follow-up. And if you have any kind of adverse events in your patients who are taking VASCEPA, you want to make sure that you call the 1-855-VASCEPA and report those so we can continue monitoring with the post-marketing data. Then obviously you should be careful in patients who are on concomitant anticoagulations or antiplatelet agents and monitor them for bleeding. So I think that covers the safety issues. Let's talk about the fact that VASCEPA is the only stable single-agent EPA. It's produced with a scientifically advanced process. Remember that icosapentaenoic ethyl is a prodrug and becomes icosapentaenoic acid as an active metabolite. So let's talk a little bit about the overview on VASCEPA. Number one is we are concerned about the fact that despite patients being on aggressive standard of care therapy, which includes statins plus ezetimibe, et cetera, that those patients with elevated triglycerides still seem to have an increased risk. And as you all know, we haven't come up with a cure for atherosclerosis. That despite our best efforts, people are still continuing to have events, regardless of the statin-based standard of care that has been appropriately discussed in all of our guidelines. So obviously, we've been looking for additional ways to reduce residual cardiovascular risk. And it is true that VASCEPA is the first and only medication that is an FDA-approved medicine as an adjunct to maximally tolerated statin to reduce MI, stroke, coronary revasc, and unstable angina, but particularly in patients with elevated triglycerides as defined by greater than or equal to 150, whether they have established atherosclerosis or diabetes plus 2 additional CV risk factors. And we'll talk a little bit about the REDUCE-IT trial and show the unprecedented CV event reductions, which interestingly were independent of baseline or achieved triglyceride levels. And maybe we'll have time to discuss that a little bit, but the benefits seem to be out of proportion to what would have been expected by the lipid changes. And obviously, many new recommendations, including our own consensus document on the use of icosapent ethyl, have occurred since the results of the REDUCE-IT trial have been published. So unfortunately, we still have the reality that cardiovascular death claims more lives than cancer and respiratory disease combined. I think this is a review for all of you, with almost 800,000 deaths occurring due to cardiovascular disease, which is significantly greater than that occurring from cancer and lower respiratory disease. And, obviously we've made huge strides since the 1950s in reducing cardiovascular death, but we still have a long way to go, and it still remains the #1 cause of death annually in the United States. Now, what's been interesting, and this is a discussion that we could spend an hour on, is that, since the 1950s, there's been a steady decline in the number of heart disease deaths annually. And you can see the data here from 2000 to 2017. And there was a decline all the way to about 2012. And since that time, there's been a slight uptick in cardiovascular deaths. We've all been aware of this data. I think the reason for it is a topic of discussion. It may well be due to the obesity epidemic and the marked increase in diabetics that occurred in the last 20 years. And those diabetics are now reaching ages of cardiovascular disease. But also the baby boomers, a huge bubble of the population, are also now reaching cardiovascular disease age. So just a lot of people that are getting into that age group where CV disease is common. Regardless of what we might guess is the cause of this uptick in cardiovascular death, it begs the question that we should be looking for additional ways to bend that curve back down to try and reduce the risk of cardiovascular death. And in terms of dollars spent, that also goes without saying, and as a review for all of you, but $318 billion being spent on cardiovascular disease, which basically accounts for every $1 out of every 6 spent on healthcare. So a lot of cost to society, not to mention the cost and burden of losing a loved one. So we know that despite our best efforts in terms of giving patients statins, that there's still a significant number of patients coming back with recurrent events. And these are patients with well-controlled LDL levels, but you can see out to 7 years, there's still about a third of the patients having events. So we're far from finding a cure for cardiovascular disease, and we need to continue to reduce the number of cardiovascular events and death. Now, in terms of triglyceride levels predicting risk, certainly in patients at risk for cardiovascular disease, you can see that there's a steady increase in risk as the triglycerides jump up between 100 and 200. And then that risk seems to continue as it goes up. And there may be a few exceptions like alcoholics and women on estrogen, but for everybody else, and particularly those with metabolic syndrome, elevated triglycerides seems to be a good predictor of risk. And you can see in the Miracle trial how much additional risk there was in patients with triglycerides over 195, for example, a 50% greater risk than those with lower triglycerides, in other words, below 135. So evidence that triglycerides, particularly in patients at risk for cardiovascular disease, is a predictor of significantly greater risk than those who have normal triglycerides. And so we have a huge bubble of the population that still have triglycerides over 150 and have established cardiovascular disease, or they have diabetes with greater than 2 risk factors. In other words, appropriate indications for VASCEPA, as was outlined in the indications section. And you'll see the data that supports that in the REDUCE-IT trial shortly. But still, we have lots of patients, so somewhere in the neighborhood of 17 million that would fit the indications. And it's not something that's top of mind yet for us, but we should be thinking about that when we see patients who have established cardiovascular disease or diabetes and 2 risk factors and have triglycerides over 150. And hopefully when you see the REDUCE-IT data, that'll make sense. So here's 3 individuals that would fit based on the current recommendations and indications. David's a 65-year-old with an MI who had coronary stents placed several years ago when he was 57. He's got hypertension, coronary disease, and dyslipidemia. And you can see his triglycerides are 185. His HDL is not too bad. It's 42. Blood pressure is borderline. And he's got an elevated BMI. So he would have established atherosclerotic cardiovascular disease. Even though his LDL is less than 70, he has triglycerides over 150. And as you'll see from REDUCE-IT, he stands to get some benefit from being on VASCEPA. Dawn is a 55-year-old. She would be without atherosclerosis, but has type 2 diabetes. Her A1C is not perfect. It's 7.9, so her diabetes needs to be better controlled. But she has other risk factors, including hypertension and dyslipidemia. You can see that her LDL is a little higher than we'd like it at 84. Even though her HDL looks pretty good, her hypertension is not well controlled. And she has triglycerides of 150, and as you'll see from the REDUCE-IT data, she would have qualified for the REDUCE-IT trial, and you'll be able to see what the benefit of VASCEPA is when we look at the study. And then James is the type 2 diabetic. He's 32 years of age. His A1C is poorly controlled at 8.3, and he's got peripheral arterial disease and smoking, so at least 2 additional risk factors with his diabetes. He's in trouble, obviously, by all of our standards. His A1C is out of line. His blood pressure is elevated for a diabetic. And his triglycerides are 320, and his LDL is not where we'd like it. So a lot of work needs to be done on him. But he would qualify for VASCEPA based on REDUCE-IT trial and the current recommendations. So once again, the indications would be established cardiovascular disease with triglycerides over 150, or type 1 or type 2 diabetes, and an additional 2 risk factors. And then you can see the risk factors to the right of this slide. And obviously, most patients who have type 2 diabetes will have at least 2 of those risk factors. So let's look at the standard of care prior to REDUCE-IT, and then the CV event reduction that was shown in the REDUCE-IT trial and where we are today. So this study, which several of us attended in terms of the presentation, was presented by Dr. Bott, was striking in terms of its results. I think many of us were really surprised with the magnitude of benefit that was shown and reduce it. And I'm going to go through the data for you so that you're aware of what was done. So after a large number of patients were screened, 8,179 patients whose LDL was well controlled with the statin. I believe their LDL had to be between 40 and 100 to get into the trial. And their triglycerides had to be 135 to 499. And what actually happened was people were screened, and if their triglycerides were 150, they got into the study. But if at their initial visit, their triglycerides were over 135, they were allowed to stay in. So there were about 10% of patients who had triglycerides under 150 by the end of the trial. 71% were patients over 45 who had established atherosclerosis, and about a third were patients over 50 with diabetes and one additional risk factor. And as you probably all are aware, they were randomized to statin therapy or statin plus ezetimibe and continued therapy with, and then active therapy with VASCEPA, and the other group was staying on their continued lipid-lowering therapy, but were given a placebo and followed up for just under 5 years, with the primary endpoint being first occurrence of 5-point MACE, which included non-fatal MI, non-fatal stroke, CV death, coronary revasc, and unstable angina requiring hospitalization. And the secondary endpoints were hard endpoints, which included non-fatal MI, non-fatal stroke, and CV death. These were the baseline characteristics of the patients. You can see on average, they were 64 years old. And as we mentioned, about 2/3 of them had established CVD, with the other third being so-called primary prevention, but were type 1 or type 2 diabetics with one additional CV risk factor. And then you can see that 10%, as I mentioned earlier, had triglycerides less than 150. And I explained why that was. They were 150 at screening, but they could drop down to as low as 135 and remain in the trial after their first visit. And you can see the LDL levels that about a third of the patients had LDLs less than 67, a third greater than 67, and a third greater than 84. And keep in mind, as I mentioned, their LDLs could be between 40 and 100 to get into the trial. You can see that, high dose statin was used in about a third of the patients, and another 60% were on moderate dose statin. So about 90% of the patients were on moderate or high dose statins, and many of the patients were on antihypertensives, and almost 80% were on antiplatelet therapy. So pretty well treated group by current standards. Obviously not perfect, but unfortunately the population never correlates beautifully with guidelines. So this was a pretty well-treated group at baseline. And what happened? Well, the group that was on the VASCEPA had a 25% relative risk reduction for the primary endpoint. And again, that was a composite of MI, stroke, CV death, coronary revasc, or unstable angina. And, whenever you see a percent reduction, you have to ask yourself, what does that really mean? Well, the absolute risk reduction was 4.8%, and you remember that 1 over the absolute risk reduction gives you the number needed to treat. So what this said is, if you had atherosclerosis with triglycerides of 150 to get in, and an LDL between 40 and 100 on good statin therapy, that you only had to put 21 people on VASCEPA to save one of these major cardiovascular events. That was almost the same magnitude of benefit that you would see giving a high-risk patient like a CVD patient a statin versus placebo. So it was a significant and rather striking benefit for the primary endpoint. Now, we know there's variations in how much revascularization is done by region, by different areas of the country, and there's even variations of what people call unstable angina, but you can't fake an MI, stroke, or CV death. So when you look at the secondary endpoints, which were the hard endpoints of MI, stroke, or CV death, which kind of would reduce any question of diagnosis or habits regarding revascularization, the number needed to treat was almost the same. It was 28, and the overall relative risk reduction was 26% for the secondary endpoint. Again, very striking to all of us who were watching that first presentation of the data. So when you looked at triglycerides at 1 year, and this is a difficult slide to kind of get your arms around because there are two lines on top of each other. So in gray, you see the statin and placebo, and actually statin plus VASCEPA, there's two lines there, one that's dashed and one that's solid. And those are patients who have triglycerides over 150 or triglycerides less than 150 in the treatment arm with statin plus VASCEPA. And what you can see is that there wasn't a difference based on your baseline triglycerides, whether they were greater than 150 or less than 150. Remember, about 10% of the patients had triglycerides less than 150 and all the way down to 135. So this at least looks like the level of triglyceride wasn't the issue. And it starts to ask the question, was triglyceride lowering the major benefit here, or was there something else? And I think that we've had a hard time explaining the magnitude of benefit by the magnitude of lipid changes in this trial. So our assumption is that there are other effects of the EPA besides the lipid changes that are causing this large magnitude of risk reduction. So in terms of safety profile, there were a few issues, though overall the drug was very safe and effective. I alluded to these earlier, but VASCEPA was associated with an increased risk of atrial fib and aflutter, 3% versus 2%, and this was more common in people who had a previous history of AFib or aflutter. It was associated with a slight increased risk of bleeding, 12% versus 10%, and that was from the REDUCE-IT trial. Again, it was more common in patients who were on antithrombotic medicines such as aspirin, clopidogrel, or warfarin, as you might expect. And the most common adverse events that occurred in greater than 3% and greater than 1% more frequent than placebo: musculoskeletal pain, peripheral edema, constipation, and atrial fibrillation. I hear my dog in the background. She always likes to get in on these presentations. And here's the overall safety data, statin plus VASCEPA, and the patients who've been exposed versus statin plus placebo. And you can see the p-values there with none of these being statistically significant over the 5 years of the trial. And that includes total adverse events that would lead to withdrawal of the drug. Now, this next section is a sub-analysis of the patients who were treated in the United States versus those outside of the country. This was not reviewed by the FDA, and it's really a retrospective analysis, though it was pre-specified. There wasn't enough power to reach definitive conclusions. So statistical interaction terms for heterogeneity for the comparisons and non-U.S. patients were not significant for most of the endpoints. The safety findings were consistent with the full study results. So this is just for your interest's sake. It isn't super solid data in terms of being powered to show a difference from the remainder of the study group, but it is interesting to take a look at. So if you look at the patients in the United States, what they saw was overall what appeared to be a greater reduction in events, with 5-point MACE being reduced by 31% and the number needed to treat being only 15. Key secondary endpoints, which was the hard endpoints of MI, non-fatal stroke, and CV disease, had a 31% relative risk reduction, which added up to a number needed to treat of about 22. And then you can see the data for non-fatal MI by itself, fatal or non-fatal stroke, cardiovascular death, and all-cause mortality. Now, it should be pointed out that all-cause mortality was not statistically significant in the overall trial, which included data from all the countries. So this is hypothesis generating, but the overall study actually showed statistical significance in all these other secondary endpoints, but there wasn't a significant reduction in all-cause mortality in the REDUCE-IT trial as a whole study. So again, interesting data that was not carefully reviewed by the FDA. So what have we learned from this? Well, we do have a pretty powerful study showing that on top of aggressive statin therapy with LDLs in the range of 40 to 70, if patients have atherosclerosis or diabetes plus one risk factor in the REDUCE-IT trial, adding VASCEPA showed a significant reduction in risk with a reduction in the primary endpoint, number needed to treat of about 21. So what do we do about that in terms of treatment? And, multiple medical societies reviewed this study, including the National Lipid Association, and made recommendations, including that the drug should be used in people with ASCVD or type 2 diabetes, as we described. In other words, high risk for CV disease. For people whose statin has controlled their LDL, but who have triglycerides between 135 and 499. Our document at the NLA said 135. The FDA and the indication in the label is 150 or higher. And again, that was based on the way people were enrolled in the trial. So you'll notice in the label, triglycerides over 150 are the tipping point for the use of this medication. And I think all the societies agreed that this was not generalizable to other products that contain omega-3 fatty acids, because, as you all know, a meta-analysis of the EPA DHA drugs did not show significant benefit across multiple trials. And most recently, the STRENGTH trial, that was a study looking at another omega-3 that included EPA and DHA, and was also a prospective randomized double-blind well-done trial, was terminated due to futility with no sign of reduction in cardiovascular events. Other things beside eicosapentaenoic acid, such as fibrates in the ACCORD and FIELD trial, did not show a reduction in risk when added to a statin. And that led to the FDA removing the approval for cardiovascular risk reduction for fibrates in 2015. And therefore, though fibrates are still useful in trying to prevent pancreatitis in patients with severe hypertriglyceridemia, we don't have any compelling data in terms of reduction of cardiovascular events based on the primary endpoints of several randomized prospective trials, whereas REDUCE-IT definitely showed benefit. A lot of discussion has occurred regarding VASCEPA versus other prescription omega-3s, as well as fish oil supplements that are not governed by the FDA. And as you can see that, VASCEPA has approval by the FDA for reducing cardiovascular risk. EPA DHA mixtures do not. They are purified as VASCEPA in terms of the prescription brands. So they are FDA approved for hypertriglyceridemia, and FDA does regulate the manufacturing process for prescription brand, but they don't have a single agent active eicosapentaenoic acid, and they haven't demonstrated any reduction in cardiovascular risk. As far as the dietary supplements, a lot of work has been done on this, and what's clear is that the amount of EPA and DHA in each capsule is not well regulated. What you read on the label may not correlate with what's in the capsule. They become rancid because they're not necessarily made in an environment where there's no oxygen. Sometimes deodorants are added to these capsules to help reduce the rancidity, and some of them even have saturated fat in them. So clearly you're not getting the formulation that's been shown to reduce cardiovascular risk, and at the present time that is only available in prescription brand VASCEPA. So this is a slide that is interesting, but I'm not sure it's scientific, but it is comparing the numbers needed to treat in multiple other trials. We said that with VASCEPA, there was a number needed to treat of 21 in the overall study. And again, with the issues related to the the data of the US subgroup, it looked like the NNT was as low as 15. But with that said, these are comparing the Fourier data, the IMPROVE-IT data, and the LipidPALOOZA data. And I would just say that these are different drugs, different studies, different patient populations, and the length of the trials were different. So I think this is interesting, but probably comparing apples to oranges. What I would say about this, however, is that the NNT is actually very low for a 5-year study. Again, as I mentioned earlier, similar to statin versus placebo in several of the statin trials. And but I have a hard time comparing them to these other studies. But it is a very low NNT that we saw in REDUCE-IT. And I will leave it at that. In terms of the safety profile and cost effectiveness, there's been a lot of data regarding safety in the Marine, Anchor, and REDUCE-IT trials without any. And we mentioned that in REDUCE-IT, the slight increased risk of atrial fibrillation and a trend towards increased risk of bleeding. The dosage is 4 grams a day, period. So keep that in mind. I see a lot of people getting 1 capsule a day, but the correct dose is 4 grams a day, which is 2 capsules BID or 4 capsules a day. And there have been cost-effective analyses showing that for the benefits that you receive, that the drug is reasonably cost-effective. So in summary, a lot of data showing significant reduction in risk, not only in the primary endpoint, the 5-point MACE, but in the hard secondary endpoints of MI, non-fatal stroke, and CV death. And then other secondary endpoints that had highly statistically significant reduction in risk were non-fatal or fatal MI, non-fatal or fatal stroke, and even cardiovascular death had, with a p-value of 0.03, a significant reduction. As I mentioned, there wasn't a reduction in all-cause mortality, but there was a definite significant reduction in cardiovascular mortality. So I think the future of how we incorporate this information into how we practice is going to be important. We want to remember who the indications are. These are patients with established cardiovascular disease whose triglycerides are over 150, or those with type 1 or type 2 diabetes and 2 additional CV risk factors whose triglycerides are over 150. We have the opportunity to further reduce or bend that curve in terms of cardiovascular mortality, but also to reduce cardiovascular risk reduction overall, even short of mortality in terms of reducing cardiovascular events. So I'm going to stop there, and I think we have time for some questions.
Excellent. Thank you, Dr. Brown. As a reminder to our audience participants, if you have any questions, please submit them through the Q&A section on the right-hand side of your screen. Dr. Brown, I'd like to maybe start with, you spoke about the surprise that you had with respect to the magnitude of risk reduction when Dr. Bott first presented the results in late 2018. Can you share with us how the results of REDUCE-IT have, changed your practice and treating persistent cardiovascular risk beyond statins?
Yeah, I think I'd speak for most of us in lipids. We were surprised. We had seen some sort of promising data with EPA-DHA combinations and some theoretical potential benefit, but overall, when we looked at all the trials combined, we were underwhelmed. And then, as you know, the JELIS study that was done in Japan showed some benefit with EPA, but it was an open label study that wasn't blinded. So it had received some criticism in terms of study design. So I think we all anticipated that we might see less magnitude of benefit. And everyone who was sitting in that presentation, I think there was sort of a collective gasp when the data was presented that, how powerful the risk reduction was. And we still talk about it. So certainly in my own practice, when I have a patient, the one that comes to mind immediately to me where I always think about using VASCEPA is a patient whose LDL is reasonably well controlled. Their triglycerides are 150 to 200, something which in the past I probably wouldn't have blipped on my radar screen as much, and who's had a recurrent event. So possibly somebody who came back now with a second angioplasty in a couple of years or continues to have events despite our best efforts. And even if their LDL is 50, which, as you know, LDLs as low as 40 were enrolled into the trial, but their triglycerides are over 150. Those are people that I think, okay, what more can we do? And, their LDL seems to be well controlled. They're continuing to have events. And in the past, we'd be thinking about driving the LDL lower, which is not unreasonable. But when you look at the magnitude of benefit of adding something like VASCEPA versus bumping up the statin or adding something else to get the LDL lower, it's hard not to think about using VASCEPA in that setting. So I think top of mind is people with recurrent events whose lipids at first glance look fairly well controlled, but whose triglycerides are over 150. And then beyond that, I'm looking much more carefully at my diabetics. And I would say that I tend to use omega-3s anyway in diabetics with hypertriglyceridemia over fenofibrate, simply because of the rise in creatinine you can see with fibrates, and that you don't see that with omega-3 fatty acids. But I tend to choose VASCEPA because of the cardiovascular outcome benefit in any diabetic who's got other CV risk factors, because what we're all trying to do is reduce cardiovascular events as preventative doctors and other practitioners.
Absolutely. Thank you. Couple of questions here about the pleiotropic effects, mechanism of action. What is the mechanism of plaque regression, CV event reduction in face of minimal LDL and HDL cholesterol? Maybe you can provide your clinical perspective on that, Dr. Brown.
Yeah, well, that's a great question. I don't think anybody really knows for sure, but there have been a lot of in vitro studies showing a reduction in inflammation and improvement in endothelial function. And also, we know that EPA tends to stabilize cellular membranes, whereas DHA is more disruptive, at least to peripheral membranes. It might be more important in the brain than it is out in the peripheral arterial circulation. But what does that do? Well, something we don't talk about a ton are cholesterol crystals in terms of cause of a ruptured plaque. So we know that inflammation within the plaque due to oxidation of lipid particles, and by the way, in vitro, there's an antioxidant effect of eicosapentaenoic acid. So with all that said, in addition to inflammation in the plaques leading to inflammatory cells secreting matrix metalloproteinase, which eats away at the fibrous cap and leads to plaque rupture, there are mechanical causes of plaque rupture also. And one of them is cholesterol crystal formation, where you have little spicules of cholesterol crystals sticking into the lumen of the vessel. And just from blood flow going by and hitting those spicules, you can rupture a plaque. And we know from in vitro studies that VASCEPA tends to reduce the formation of those cholesterol crystals. So probably all of those, antioxidant effect, anti-inflammatory effect, which go hand in hand, by the way, improvement in endothelial function, and reduction in cholesterol crystal formation may be part of the benefit. Very recently, we had data presented at ESC from the Evaporate trial that showed CT evidence of some plaque regression also in patients on VASCEPA versus placebo. So that was encouraging to see at least some structural changes on imaging compared to placebo when we saw such striking, clinical outcome data from REDUCE-IT. And the two sort of correlate with each other, which was encouraging.
Great. Thank you, Dr. Brown. Question here from another audience member. Would you still use VASCEPA in a patient that has reached goal in LDL and non-HDL if their TG is 150?
I would if they fit the indication. In other words, they have established atherosclerosis, and they have type 2 diabetes plus 2 additional risk factors. I think, even though their non-HDL may have been well controlled, some of those patients were enrolled in the REDUCE-IT trial and they got benefit. So I would follow the indications in the label. And I think those patients should be the ones that get benefit. And that was what the FDA determined also.
Very good. Another question. Can you comment on a patient with very high triglycerides over 500 and your use of VASCEPA in that patient population?
Yes, that's a great question. So if the patient qualifies for VASCEPA, I tend to use it because it's the only omega-3 preparation that's been shown to have cardiovascular event reduction. And there are two indications. One is the decision regarding atherosclerosis or diabetes with 2 additional risk factors. But the other indication is still triglycerides over 500. So even in the absence of established ASCVD or diabetes, I would consider using VASCEPA. I will say, however, that as you all probably realize, sometimes you get pushback from payers if they don't have underlying atherosclerosis to use VASCEPA just for hypertriglyceridemia. It would still be my first choice for a number of reasons, but assuming that I couldn't get it covered, if the patient did not have ASCVD, did not have diabetes, then I would be comfortable using EPA-DHA combination just to avoid the risk of pancreatitis, or to use fenofibrate if necessary, or both. And sometimes it's necessary to use both.
Very good. Thank you. Question here about attempting to increase EPA-DHA through food intake, through salmon, et cetera. Thoughts there? Can a benefit be achieved through that route?
No, that's another great question. Observationally, it appears yes, that eating fatty fish will, number one, raise blood levels of omega-3s. And observationally, it's not a randomized prospective trial. People who tend to eat more fish seem to have a lower CV risk. Is it because they're eating more fish or because they're eating less red meat? I mean, that's all been a big controversy lately if you've been reading the literature. But also, even in some of the EPA-DHA studies that overall were negative, it seemed like there was potentially a little benefit in patients who had lower blood levels of EPA and DHA, or who were eating less fish. So I think the jury's still out. We don't have a great prospective randomized trial, but at least observationally, it looks like it's good for your health to eat fish that are high in omega-3s. Keeping in mind that that's not perfect science.
Okay, thank you, Dr. Brown. Another question here. Can you provide your clinical perspective on the AFib, aflutter risk that was seen relative to, kind of the downstream benefits?
Well, again, AFib and aflutter are very common. I would say it's the most common thing as a cardiologist that I get called for in terms of consultations. And it's often more common in people who are overweight who have sleep apnea, but who also would have metabolic syndrome. So it's hard for me to sort all that out. There was a slightly higher risk in reduced of AFib, and particularly in people who had previously been in atrial fibrillation. I have no idea what that mechanism is. There have been small papers published in the past suggesting that the omega-3s may actually reduce the risk of atrial fibrillation, and that hasn't really borne out. So the right answer is I don't know. I think we have to look at those patients specifically in detail, determine whether they were exactly the same as counterparts in the trial with regard to risk factors for atrial fibrillation, and that the only difference was that they took the VASCEPA versus placebo, or whether, they just had slightly higher risk for atrial fib because of sleep apnea, obesity, meds they were on, etc. So it's a very interesting finding. It's one that one should think about, but those patients weren't randomized for risk for atrial fibrillation. So there's a potential there that it could have been noise. And that's why it's so important to do the post-marketing reporting if you have patients who develop any kind of adverse events, because as we get it out into the broad population, you start to find out whether these are real side effects related to the medication.
Fantastic. Thank you. Another question we hear a lot, do you consider a positive coronary calcium score as a valid criteria for diagnosis of cardiovascular disease?
Another great question, and whether I consider it that or not is, not as relevant as what the payers consider. But I think we have good evidence that with a coronary calcium score over 100, that at least statin therapy versus placebo reduces people's risk. I consider any calcium score elevation as a sign of subclinical atherosclerosis. So I'm pretty aggressive. But as some of you know, at least with regard to statins, a 10-year retrospective analysis from Walter Reed, I believe it was, suggested that if your calcium score was over 100, you clearly got benefit on a statin versus those who were not. And then the current recommendations suggest at least some sort of imaging stress test with calcium scores over 300 and over 1,000. We know patients are at a very high risk. So that's a long answer to a short question. I consider coronary calcium as a sign that the patient has atherosclerosis. And obviously, if I felt that an omega-3 prescription preparation was necessary for that patient, that would be a patient I would be reaching for VASCEPA first because of the outcome data.
Okay, great. Maybe one more question here. How do you counsel patients who are taking dietary fish oil supplements for a perceived cardiovascular risk reduction?
Yeah, I mean, it goes back to the GISI Prevenzione study where they gave EPA-DHA combination to patients with coronary disease, and they had a combined endpoint that included hard cardiovascular events as well as sudden cardiac death, and they showed a benefit in sudden death only. There was no reduction in revascularization, MI, or other endpoints other than sudden cardiac death. But at that time, a recommendation came out, I believe, from AHA that everybody should be on omega-3s, and that got patients taking over-the-counter fish oil. Further evaluation, trying to decide whether the omega-3s reduced ventricular fibrillation, was certainly controversial. There was a study in patients who had defibrillators that actually had more defibrillator discharges when they were on the omega-3s than not. So, I mean, it's all out there as we don't know. What I counsel patients is if you're spending a lot of money on an omega, taking one fish oil capsule a day over the counter, save your money for either your health savings plan or your next vacation. There's not much evidence that does any good. And I do tell them it's probably better in that setting where they don't have diabetes or atherosclerosis to eat more fish and eat less saturated fat in the diet, even though I realize recently that's become a controversy. But that's what I tell the patients.
Excellent. Thank you, Dr. Brown. Before we close out, maybe I just turn it back to you for any final thoughts that you'd like to share with our audience today.
Well, I'd just like to thank you all for taking the time to listen to the presentation. I hope the data from REDUCE-IT struck you as it did me. And, I would recommend that when you have a patient who fits the indications for VASCEPA, that you think about it. And occasionally you will find some difficulty getting coverage for it, but I have found that going directly to a peer-to-peer review and being able to discuss why a particular patient is best served with VASCEPA versus some sort of generic omega-3 has been quite fruitful. Letters and other things have not done much for me, but a peer-to-peer conversation and a discussion of the results of the REDUCE-IT trial have usually led to approval for my patients. So I will just leave you with that. I thank you very much for your time and for listening to the presentation.
Very good. Thank you, Dr. Brown. And on behalf of Amarin Pharma, I'd like to thank all of our attendees for joining us this afternoon. You can connect with us at our booth at the NLA's virtual exhibit hall at lipid.org/fallCLU. And I would remind you to tune back in at 3 p.m. Eastern for a special presentation titled Recognition and Treatment of HFH in the Real World Practice, a nationwide survey of cardiologists and primary care physicians from the NLA's Health Quality and Research Committee. On behalf of Amarin, thank you, and this concludes our product theater.